Hello, everyone, and thank you for joining us this evening for week 6 of the Rugby Research and Injury Prevention Group 2025 Journal Club. We will begin our first Journal Club presentation with our first intern, Nadira from Adelphi University. Nadira will be presenting on sex differences and injury rates in team sports athletes. Nadira, will you please share your screen?
Yes, thank you, Lawrence. Can everyone see my screen? Okay, that's great. All right. 1 second, please. Okay. Good evening, everyone. My name is Nadira Peaks, and tonight I will be presenting an article titled "Sex Differences in Injury Rates in Team Sport Athletes: A Systematic Review and Meta-Regression Analysis." This article was featured in the Journal of Sport and Health Science and was published in 2022. So some background. Injury in sports has been extensively researched through the years. Team sports in particular seem to have high risk of injury due to the complexity of the game, team members, or even opponents. A frequently overlooked aspect of epidemiological injury data is sex-specific differences throughout different kinds of sports. There are a number of systematic reviews and meta-analyses that focus on injury rates of soccer or football and rugby, but fewer data is available for other team sports such as volleyball, handball, and ice and field hockey. There is a gap in that is the lack of clear comparison of sex differences in injury rates within the same sport. So these were the main objectives of this study. First one was to systematically compare injury rates between male and female athletes. And to do this, we will use meta-analysis and meta-regression. And this study focused on 6 kinds of sports: soccer, basketball, field hockey, handball, rugby, and volleyball. So the search for different kinds of articles were found on PubMed, Web of Science, and Google Scholar. To find these articles, there was a specific criteria that an article needed to have. It needed to be involved in a prospective cohort design. You need to have injury or exposure data. They need to have data for both female and male athletes. You need to appear in peer-reviewed art journals. You needed to report acute or overuse injuries. And the player age needed to be greater than 16 years old, as well as have the reported injuries in a high level or collegiate league or in major senior or youth tournaments. So for the data abstraction in this meta-analysis, towards the left over here, we have a PRISMA diagram. PRISMA stands for Preferred Reporting Items for Systematic Reviews and Meta-Analysis. It acts as a flow chart. So there were around 20,000 studies that were first inputted into this meta-analysis. And as you go down to the different stages, you can see some studies getting pulled apart due to, for example, having duplicate records or records excluded. But in the final meta-analysis and meta-regression, there were a number of 20 studies. So some of the information for the 20 studies were retrieved. You needed the sample size, sample characteristics, which considered age, level, and nationality of players, exposure data or exposure hours for female and male players, whether it be tournament or season. You needed the injury definition, the time loss, all medical attention, or physical compliance. Extracted injury data were overall match, training, severe head, upper extremity, trunk, hip or groin, thigh, knee, ankle, and foot injuries such as ankle sprains, as well as general sprains, strains, concussions, hamstring injuries, and ACL and Achilles tendon ruptures. Severe injuries were defined by a time loss of 28 or more days following the injury in this article. So in the article, they bring up an incidence rate ratio. An incidence rate ratio is a statistical measure that compares the incidence rates of an event between females and males. The incident rate ratio is calculated by taking the number of injuries of female athletes and dividing it by exposure hours of female athletes, and dividing that entire incidence for the female group divided by the number of injuries of male athletes divided by exposure hours for male athletes. So it's basically a ratio of incidence between female to male. The interpretation in this study of incidence rate ratio is when the incidence rate ratio is less than 1, it indicates higher injury risk in males. When the incidence rate ratio is greater than 1, it indicates higher injury risk in females. And when the incidence rate ratio is 1, it indicates no difference between the sexes. So for the results, in the subgroup of overall injury, the overall injury for the incidence rate ratio between females and males was 0.86. You can say that with 95% confidence. This incident rate ratio indicates a higher injury rate in male players. The meta-analysis of subgroups showed that this effect was substantially significant for soccer, which had an incidence rate ratio of 0.75, and handball, which had an incidence rate ratio of 0.76, both having 95% confidence. And the effects for the other sports were not statistically significant. Regarding the match injury subgroup, the pooled incidence rate ratio between females and males for matches was 0.90%, and that is with 95% confidence. The effect of the incidence rate ratio showed no significant differences between sexes. And furthermore, the subgroup analysis identified no significant sex-specific differences in the match injury rates in any single team sport. There were no significant moderators for the match injury incident rate ratio between females and males in the meta-regression analysis. Regarding training injury for the subgroup, the incidence rate ratio during training in all team sports was 0.87 with a 95% confidence interval. In the meta-regression analysis, the injury definition was the only significant moderator with a p-value of 0.045 of sex-specific differences in training injuries. For the subgroup injury by body location, the pooled incidence rate ratio showed significantly more injuries in male players than female players for areas including the upper extremity. The incidence rate ratio is 0.75 for this area. The hip/groin area, where the incidence rate ratio is 0.6. The thigh area, where the incidence rate ratio is 0.69. And the foot area, where the ratio is 0.64. This was all done with 95% confidence. Meta-regression identified player age as a significant moderator for the hip/groin incident rate ratio. The type of sport was a significant moderator for upper extremity, trunk, and hip or groin injuries. And volleyball was not included in the regression analysis. So this is a table that was based off of the injury by body location, the previous slide. And it shows the confidence intervals. It shows the pooled incidence rate ratio and I-squared, which is just measures heterogeneity, which is the variability between studies. So the higher the the higher the values, the more variability that in the studies. So for example, you can see the circled part over here, 0.69. The 10 represents the number of articles that were related to the thighs, and the incidence rate ratio is 0.69. Down over here, For the meta-regression analysis tests whether variables like tournaments versus season, injury definition, age level, and quality of students significantly explain differences in the incident rate ratio. This incident rate ratio this p-value is less than 0.05, which means that it was statistically significant. That's over in the hip and groin area, as well as age level. For these three p-values over here, we know that upper extremity, trunk, and hip and groin area for the type of sport like field hockey and rugby, they were statistically significant. For the subgroup titled with specific injury types, these were the results. For ACL injuries, the pooled incidence rate ratio indicates a significantly high rate in females compared to male athletes. And there were no statistical significant differences in sprains, strains, concussions, or ankle sprains or Achilles injuries. The meta-regression analysis found no significant moderators in affecting the incidence rate ratio differences between females and males. And over here, we have another table that is based off of specific injury types. For this circled value over here, we have the articles that were related to sprain and the incidence rate ratio, which is 0.90. And then for the meta-regression for tournament versus season and the 10 articles based on concussion, the p-value is greater than 0.05, which means that it was not statistically significant. And there are no values in any of these columns due to the fact that they were all less than 10 articles. And for the type of sport, the football or soccer versus basketball, 0.470, and all of these values over here, they are all above 0.05 for the p-value, which means they are not statistically significant. So some moderators and limitations that were introduced in the study. Moderators were the type of sport, injury definition, age level, competition, whether it be tournament or season, and methodological quality score were considered to be potential moderators of sex differences in injury rates in the meta-regression analysis. And some limitations with this study included small sample sizes in non-soccer sports, inconsistent surveillance definitions, and lack of studies in sports beside soccer or rugby. So some conclusions for this article. The meta-analysis in the study provides evidence for sex-specific differences in the injury rates in sports teams, and further epidemiological studies including both sexes in sports other than soccer are needed in order to strengthen these evidence. This is the reference that I've used. Thank you. Are there any questions?
Thank you for that great presentation. Are there any questions, or Dr. Lopez, do you have anything to add?
Yeah, if you don't mind, Nadir, why don't you go back to the initial table you presented that shows the comparison between sports? Yeah, there you go. Was it this one? Yeah, this one actually. So it was football and field hockey, but it was soccer. And so actually we should just consider soccer. Soccer versus basketball, soccer versus field hockey, handball, and then obviously, I'm quite surprised that I know handball has quite a bit of injury to the lower extremity, if anyone knows how European handball is played. So there was no significant differences, let alone in the knee or lower extremity, which is kind of surprising. And then obviously, if you saw Dr. Roberts' data just before, we were talking about the knee and the knee is the number one injury, and ankles definitely up there. But for soccer versus rugby, they discussed trunk, hip, and groin significance. I could definitely see the running, the groin pulls, the trunk maybe with the tackles. So that's, I guess, you could consider that. But due to the tackle, um, I would have expected a little bit different numbers. I mean, even we're just briefly talking about the biomechanics of the injuries within these sports, and let alone basketball didn't even get significant near for the ankle injuries that they have. Just interesting the numbers that they found. Obviously, I have to look at the paper in more detail, but definitely you could see from the biomechanics I'm talking about, the varying sports, that even if the number is a little closer to maybe significance, I would have expected it a little bit. But anyway, interesting nonetheless.
Yes, I understand what you were saying. It could be due to the data, or for the meta-analysis, there were a lot of articles that were shaved off, and the selection criteria was very specific. And as if I recall, there were around 3 to 8 studies in basketball.
Mm-hmm.
So that could be a possible reason as to
Yeah,
why
an
it looks like
influencer
this.
and the outcomes of the analysis, obviously. No, good job. Like I said, very, very good paper to present at this juncture when we're starting to look at the variations between um, sex and also sports. So thank you very much for presenting it.
Thank you.
All right, if there are no more questions, we'll continue on to our next intern. We have Violet from Ithaca College. Violet will be presenting on health conditions among retired rugby players. Whenever you're ready, please share your screen.
Thank you, Larry. Share now. Can everyone see my screen? Perfect. Okay. So yes, as Larry said, I will be speaking on the health conditions among retired elite rugby players. This article was published in 2023 in the BMJ Open Sport and Exercise Medicine article. So just a little background on the article. Rugby, especially at the elite level, is physically and psychologically very demanding. It's a high impact sport, as we know, with one of the highest injury rates in professional athletics, especially. There is a growing concern regarding long-term health effects that linger into retirement, specifically within the areas of mental health, joint degeneration, and cognitive decline. There is also some literature on injuries during active play. However, there are still gaps in research on the prevalence of health conditions among retired elite players, particularly for female athletes. And there seems to be a pattern following female athletes in regards to how much data they have collected on them. So I will talk about that a little bit more later in the limitations slide, but just keep that in mind. So the purpose of the study was to present an overview of the existing epidemiological evidence in retired elite male and female rugby players regarding the prevalence of musculoskeletal, cardiovascular, neurocognitive, physiological, and gynecological health conditions. And it was also to identify research gaps concerning retired elite female rugby players and inform better health strategies for this specific population. So some of the methods that was used in regards to scoping review framework was based on the Joanna Briggs Institute methodology, also known as JBI, which provides structured guidance for identifying and charting research as well as its quality of the research itself, and the ARCSI and O'Malley framework, which is a foundational model for scoping reviews that emphasizes broad research mapping, followed by the PRISMA SCR guidelines, which stands for Preferred Reporting Items for Scoping Reviews, and it's a checklist for reporting. Another method that was used was the database search. They used databases like Medline, Sport Discuss, Psych Info, and Embase, using terms like rugby, retired, and health conditions. They were limited to studies in English, Dutch, and French with full text availability. And as you can see, they also used the Boolean search method, which we've discussed in previous meetings, and Gabriel has also gone over ways to specify our research and minimize limitations or minimize different ways and focusing on what we want to look for and what we're not interested in looking for, depending on what we're researching. And lastly, their inclusion criteria were studies focused on retired elite rugby players. Both male and female were searched, but only male studies were found, unfortunately. They must have reported prevalence data for health conditions and as well as included cross-sectional case control and cohort studies. Initially, there were 573 citations searched, but they were able to narrow it down to 16 studies, and all studies focused on male players. No qualifying studies on retired elite female rugby players were found once again, which is definitely a huge limitation because it's missing a whole group of a whole population. As for the results, in terms of musculoskeletal conditions, osteoarthritis had a 51 to 60% prevalence, and it was significantly higher than that in non-contact athletes and general population. As for neurocognitive, there are mild cognitive disorders seen up to 57% of prevalence in players, and some evidence of Parkinson's, abnormal brain structures such as CSP, and cognitive decline. As for cardiovascular, there was hypotension reported in 28 to 32%, and there were other cardiovascular disorders were rare, so they were not mentioned. Continuing on to psychological, depression was up to a 49% prevalence, which is significantly higher than in amateur or non-contact athletes. Anxiety was up to 42% prevalence, and alcohol misuse was also from 24 to 54% and often higher than the comparison groups mentioned in the study. Some other conditions reported were asthma, diabetes, and disabling headaches. As for the discussion, musculoskeletal high osteoarthritis likely was from repeated joint trauma and injuries during playing careers, and long-term joint stress leads to earlier degeneration. As for neurocognitive, evidence of mild cognitive disorder and brain abnormalities suggests accumulative head trauma and subconcussive impacts. CSP and Parkinson's signs may relate to chronic neurodegeneration, excuse me. Cardiovascular, there was elevated hypertension, which may result from post-retirement lifestyle changes like less activity, weight gain. As for cardiovascular, a continuation of it, cardiovascular disease rates otherwise were low, possibly due to earlier fitness. Psychological, they had high depression and anxiety, reflect career transition stress, chronic pain, and possible brain trauma. Alcohol misuse may be a coping mechanism for pain and mental health issues, which is common. Other conditions are the presence of asthma, diabetes, and headaches, which adds to overall health burden. And it's just a need for ongoing holistic post-retirement care, and that needs to be studied more on and also focused more importantly. So just some key takeaways are that osteoarthritis and joint pain are major long-term consequences for elite male rugby players specifically. Mental health issues are common and often under-addressed, given that the fact that the study was mainly focused on male. It's important to note that as males growing up, they're often told to not discuss how they feel or be open about their emotions. So this could possibly have a role to play in their upbringing and their environments that they were in. Cognitive impairment is significant and raises concerns about long-term brain health post-retirement. Female athletes are also missing from current research, so this highlights an urgent need for gender inclusive studies. And these findings suggest that transition support programs like ARCC, which is after rugby career consultation, are critical for managing long-term health in retired players. So some limitations of the study were that, of course, there was a lack of female data that addresses health conditions in retired elite female rugby players, which leaves some major research gaps, which then again is a more of an occurrence is happening now based on the presentation that we just watched, um, and based on Nadir's presentation as well. It's very common that females are being left out of these studies, so I think that it's important for us to make note of that and maybe put in our own studies just for future references. There was a reliance on self-report due to most studies using questionnaires or interviews, which we all know are prone to bias or underreporting, as we can't, it's not, it's not as effective to trust um, someone's view of themselves, as well as inconsistent measurement of tools because of the variety of definitions or thresholds for diagnosis. An example of this would be the depression, how people feel on a scale of 1 to 10, or however they're reporting these things, or alcohol misuse. It varies, and it's very difficult to figure out how to compare all these different measurements. And lastly, small and specific samples. So some studies lacked proper control groups, or they focused on very narrow age bands, like under 51 or between certain age groups. It just makes it a little bit more impossible to figure out how to go about doing these studies. And these are my references.
Thank you for an excellent presentation. Are there any questions, or Dr. Lopez, do you have anything to add?
So thank you for the presentation. I think what's you pointed out, Violet, interpreting self-reported data is always very difficult, especially if they're going to be self-reporting clinical data. It's challenging to for a layman person to correctly diagnose or report cardiovascular health conditions, anything of that nature. That's one. Um, and then obviously the concern with transcription bias, you know, to medications and diagnoses. I don't even know if some of the people that I know the full names or the appropriate names of medications. How do they know the difference? Um, that's the only major challenge with this study. I think their intentions were phenomenal because I know the group and they're trying to look at what's going on. Um, but again, they're looking at an older playing population that already has questionable challenges psychologically, psychologically and psychiatrically. So they need to be really monitored appropriately, let alone with major issues post play. I just think that there's a challenge when you look at that data and you try to crunch it or analyze it. That's really what it becomes problematic. In the manuscript, I think further, like they don't even maybe, a little bit into the manuscript, they describe that it's a self-reported or self-assessment. So it takes a moment for you to realize where the data is coming from, if I'm correct. Am I correct, Ms. Torres?
Yes. And I also forgot to mention that they also didn't include any tables or graphs for us to visually see into all the data holistically. So I feel like that was another limitation that I didn't mention, but that was something to make note of. And maybe that's, as you said, it was difficult to crunch the numbers all together and possibly.
The limitation section definitely needs to be rewritten. It just needs to explain things a little bit better. Anyway, good job. And I think, like I said, I think the group really tries to do the right thing with their cohort. And you could just imagine trying to reach out to retired players. They are probably post their prime. And then, as you saw from even diet, lifestyle changes, that they're being affected by. Thank you.
All right, with that, we'll move on to our third intern. We have William from Howard University. William will be presenting on isometric mid-thigh pull performance in rugby players. William, will you share your screen?
Can everybody see my screen? Okay. Good evening, everyone. Today I'll be talking about isometric mid-thigh pull tests and the performance in rugby players. This is a systematic literature review. So aims. So some of the aims from the study was to compile and summarize isometric mid-thigh pull, also known as IMTP, performance data from rugby players across different levels and codes. So this would be from union, league, club, sevens, and 15s. Also to critique and assess the quality of methodologies and reporting standards in the IMPT tests. And also to encourage standardizing testing procedures and reporting for more reliable and normative data. So what is the isometric mid-thigh pull test? So it is basically just a reliable way to test maximal strength in youth and adult athletes. It's a test that is a safer and more time-efficient method rather than the traditional one rep max testing, which also benefits athletes with a low training setting. Usually athletes, they try to do one rep max to see what their max rep is or max weight they could do on a certain machine or weight. So yeah. And also the IMTP is use of isometrics and can be used in training programs to efficiently develop strength, power, and tendon stiffness. It also provides objective data to monitor athletes' progress over time to guide and visualize training adjustments. In this table, you can see how the data is actually being taken. So it's being taken by the RFD, which I'll be going to later, and also the peak force, which is the amount of force that the athlete peaked at. So why can we use for rugby? So it helps gain understanding about strength and the ability to apply forces rapidly. It's mainly used for its high contact nature like rugby is, and the ability to generate high amounts of force in a short period of time. Since rugby is a high power and a very, very fast sport, it can be used for it and it's perfect for it. It is on the rise. It usually isn't used for rugby, but it's been on the rise for the last couple of years. And it's also essentially for tackling, scrimmaging, and scrumming and breaking through contact. It also can detect force asymmetrics between legs, and also it helps identify and manage injury risks from dominant side overuse or past injuries. It also is safe for in-season monitoring, following strength staff to assess neuromuscular fatigue and readiness without risking injury. So what is peak force development, also known as PF? So basically what it is the highest level of force that a muscle or a group of muscles can generate during a specific movement or contraction. It's a reliable indicator of maximal strength, essentially for sports that where force production is critical. So like football, basketball, rugby, and track and field. The reason for this is because these sports, they require high amounts of force in a shorter period of time. They really require burst, and you have to be able to have a burst in order to do well in the sport. It also is used to evaluate strength changes over time, particularly during training or rehabilitation, and how it applies to the IMTP test. So when an athlete pulls as hard as possible against like the immovable bar or barbell, it's usually while standing on the force plate. And the force plate, what it does is it records the vertical ground reaction of the forces. And peak force is the highest force value reached during the test. Like I said before in the slide before, in the graph, not the graph, the table, the highest force that was reached was known as the peak force. So rate force development. So RFD is calculated by the change of force over the change of time. It's expressed in newtons or per seconds or kilonewtons. And an athlete pulls as hard and fast as possible against the immovable bar. And force plates are measured by force output frame by frame, often in milliseconds. And RFD can be calculated over a specific time of the windows. And RFD is important because it shows explosive power, critical in sports requiring quick and explosive movements, like I said before. In neuromuscular efficiency, it has a high RFD that reflects the efficient communication between the brain and the muscles to generate force rapidly in a short amount of time. And rehab monitoring in recovery, especially like post ACL or MCL injuries or hamstring injuries, RFD can highlight lingering defects when max strength returns. So usually when a player gets hurt, they'll do IMTP tests in order to see how the player is progressing. So they could do it in 1 week and then the next week to see how great of an impact the athlete has gained from getting injured. So how to perform the test. So required materials that you need are a force plate that can record up to 1,000 hertz, a barbell that can be adjusted to different heights, including different heights, and also a way to secure the barbell to disallow movement. So step one is you just stretch and prepare, and then next is you got to step onto the force plate with both your feet on each plate and have your thighs touching the bar. And also the next step is to wrap your hands around the bar without pulling. And then shoulders back, chest up, and then look straight ahead, then pull the bar. And then you see the results on the muscle meter. And then you rest between 1 and 2 minutes between each trials. So you can see here, the picture here, he has his bar touching his thighs and he has both feet on the force plate. This is an accurate representation of what to do. So since the study is a literature review, this is how the article search was done. They used the PRISM, which is the preferred reporting items for systematic reviews and meta-analysis. So first is the identification phase. In this phase, they found articles that relate to the subject. And they did the screening. So they basically just remove the duplicates and just screen the studies. And after that was the eligibility. And this was found to see what articles were eligible to the study. And then lastly was included. This is the final step. So as you can see, the number started off with 620 articles, then it was cut almost in half to 347, and then the 24, which is the last number of articles that was used in the literature review. So this is the criteria. So articles that were included they must obviously be rugby players in any age and sex and level of playing were acceptable. And the rugby union, like I said, for rugby league and rugby union and rugby sevens were all accepted. And also collected and reported any kinematic or kinetics force or other data of the performance with isometric bit pool tests. Also, dissertations and thesis were in conference publications were also accepted as well. And also had to be written in English. And the articles that weren't accepted were articles where had non-rugby athletes and results of rugby players cannot be distinguished from the rest of the sample. Also, review articles, position stands, and books were not included, though they were used for screen for other references that may need to be consideration. So basically be used for other studies. So this is the procedures and how it's done. So each stage or step is recorded 1 through 14. We only have 10 here. So participant sport experience was rated from 0 to 2, 0 being not reported and 1 being reported generally only in the study, and 2 being reported specifically all throughout the study. And this is done for each and every subject. So also, for example, participant sport experience and the participant's competitive level. And this will then be put onto the chart, rated through 1 through 3. And then this is done for each of the 14 different stages. And this is for done all 24 of the articles. Then the articles are then ranked on a scale from 0 to 100%. And then this is the final results. As you can see, the results are below average, with the final average score being 40.6% from all the articles. So the results, like I said before, from the 24 research publications, data extracted from the 24 articles included subject characteristics, force data, and IMTP test procedures. So 20 peer-reviewed articles were included, also three dissertations and thesis, and 1 conference poster. And most of the studies rated below 50%, like I said before, with the average quality rating of the studies being 40.6%. 2 pairs of the journal articles were reported on data on the same sample, and also 11 studies were in professional or Olympic level rugby players, and 2 studies in exclusively academy players, 4 were university players, 4 in amateurs, and 3 adolescent players. Over half the studies, with number 13, were conducted on players from the United Kingdom. 4 studies were done with players from the United States, 3 were in New Zealand, and 1 from Australia, France, and Portugal. As you can see, this is the example of how the study was done, or how the study table was concluded. So first look at the study, the number of the study, then a population, and then the population meaning who was the study being done on, and the time of the season, where the season started, and then the knee and hip angles. So the first one is a knee angle of 135 degrees measured by the geonometer hip angle, which is not reported. Then also to see if the peak force was measured, and then you say yes, and then the RFD was measured, and then some of them say no, some of them say yes. And here are the results from the mean force over the total body force production of rugby players by code and playing level. So in the table, you can see orange meaning rugby sevens, green meaning rugby league, and blue meaning the rugby union. Each of the forces then categorized by the university in Olympic level, youth level, and academy level. As you can see from the rugby sevens, there's a gradual increase in professional level play by mean force. And then whereas you see from the rugby league, there's a gradual increase from academy to all the way to professional. And then youth rugby in U15 and U16 to 18, there's a gradual increase right here. And once you continue to university, it then increases to a max peak, which is at 5,000 newtons. Like I said before, the rate of force development RFD at 100 and 200 ms range from 5,000 to 11,000 newtons and 5,000 to 8,000 newtons, respectively. And mean force range from 1,000 to 5,000 newtons, as I said before. And these forces range from university, youth, academy, and professional play. And a gradual increase is found as there is an increase in level of play. So 23 of the 24 studies reported peak force, but only 8 reported rate of force development and only 1 reported impulses. Of the 24 studies included in the review, while all reported peak force, only 5 reported instantaneous force of average rate of force development. And also, among the professional rugby league players, unscaled peak force did not correlate with vertical jump, meaning that power or spring speed, but force scaled to body weight did. So what this means is that they found that IMTP levels was mainly related to body weight rather than force, or rather than like the vertical jump power of players. So some limitations from the study are that the IMTP study was test, and the equipment was needed to perform the test. Most coaches did not have a force plate. Force plates can cost anywhere from $5,000 to $50,000. So some coaches or some schools that may be starting up their programs may not be able to buy a force plate or be able to afford a force plate. And also a lack of standardization on procedures of conducting the IMTP test. So it makes comparisons between studies difficult, as some differences in procedures such as body positioning. And also heterogeneous populations. Studies were included at a variety of participants, like trained athletes and untrained individuals who may be starting the sport of rugby. So this also may affect the consistency, and applicability of the findings. There's no way to tell if the athletes have a background in strength testing. So some athletes may have been doing strength testing all their life, whether it be in rugby or different sports. Whereas some other athletes may not have been introduced in strength testing, may not even know what the sport of rugby is. So it's kind of hard to differentiate between who has a background in strength training and who doesn't have a background in strength testing. And also measurement inconsistencies. Some of the studies measured RFD over time intervals. Examples were 1 to 100 milliseconds and 0 to 200 milliseconds. This makes comparisons less reliable to relate to each other. So to conclude, trends for greater force production with an increase in playing level and age, there's a great deal of heterogeneity between the studies. And IMTP is a reliable and safe method for assessing maximal strength and explosive power in both youth and adult athletes. It should be used instead of 1 repetition maximum studies. And also is to compare it to the traditional one rep maximum studies. IMTP is more time efficient and less risky and better used and suited for studies for athletes with low training age. Using references. And thank you. Any questions?
A great presentation. Are there any questions, or does Dr. Lopez have anything to add?
Thanks, William, for the presentation. I think, they did a great job of attempting to synthesize the data. You can imagine trying to pull this particular information out to give to the public. Not only that, to try to figure out how to process it. You did a good job there for your limitations and the conclusion section where you described what could be done and applicable versus what can't be done.
Yeah.
And I think, that's always a take-home measure, the clinical, pearl of how to apply this in a cohort. Again, you did a great job with the presentation. Thank you.
All right, that will conclude week 6 of the Rugby Research and Injury Prevention Group Journal Club. Thank you all for attending.